Thank you all for being here one more time. And my name is Tabinda Sheikh, and I work with the Policy and Planning Branch at the Department of Health and Wellness, and also a member of the Diversity Committee. I have here with me a few presenters, starting with Caroline Whitby. She's the Thrive coordinator and is going to talk to us about the Thrive strategy. And then we have Heather Prott. She's the coordinator for special populations and disparities with the Physical Activity, Sports and Recreation branch at the Department of Health and Wellness. And then we have a couple of folks from DHA Aid. It's Reverend Sandra Morrison, who's the Director of Spiritual Care and Volunteer Services. And we have Buffy Harper. She's the Professional Practice Coordinator for Spiritual Care. Thank you very much for being here. And Carolyn.
I'm not used to sitting for long, so I'm going to stand, and if you feel more comfortable standing, we seem to have a culture of sitting in meetings, but if standing's more comfortable for you, please feel free to move to the side of the room and stand. The release last summer of Thrive, I think, was a recognition by government of the importance of health equity and action, the need for action across government. As I think was noted earlier, equity and health, it's about making sure that all persons have equal opportunity to develop and maintain health through fair and just access to resources. I think the other thing that we need to remember is that 75% of the factors that affect our health are outside the healthcare system. So it requires the health sector to collaborate with other departments and with others in society. And I think to remember that our health improves with every step up the socioeconomic ladder. So let's just have a look at the health impact pyramids. Many of you, I'm sure, are probably familiar with this already. But when we think about Thrive and we look at the pyramid, it's the bottom, the socioeconomic factors that we're looking to create change and support, because what we know is that we can have most impact on more people by working at the bottom of the pyramid. So that is what Thrive is looking to do. We're looking, the evidence was looked at, there was broad consultation, and the focus is on creating supportive environments to improve the health of everyone, but with a specific focus on healthy eating and physical activity. As you can see from this slide, that there are 4 key directions that we want to ensure there's support for all Nova Scotians. The first one, a healthy start. A lot of the work in that area is around creating supportive environments, for example, around breastfeeding. We know the evidence is that the longer people breastfeed for, there are really positive health outcomes. It's important to equip people with the skills and knowledge around food and physical activity. So the work is around ensuring everyone has what we call physical literacy skills. So as we teach people to read and write, we need to ensure that they're competent and confident movers. It's like the ABCs of reading and writing. We need to give them the skills to prepare the food. We need to create environments so people can eat well and be active. So a lot of the work in this area is around policy work, for example, food policy work within publicly funded institutions. And then the fourth direction is around creating healthier communities. And a lot of the work is around active transportation. How can we move about our communities and move away from a culture of cars? But I think one of the important things when we think about health equity is the fact that this is built, the strategy is built on a foundation of social policy with a specific commitment to introduce health impact assessment. So it's the idea of health in all policies. So that when policies are being created, the thought and consideration is given to the impact that it will have on the health of the people. And the policy piece, I think we heard Sheila talk earlier about the food security work, a key part of Thrive. And we're going to hear Heather talk shortly about the Municipal Physical Activity Program, where just last month there was the signing of the first Memorandum of Understanding with the Mi'kmaq community at Member 2 to support physical activity within the community. So it's part of a broad government prevention strategy. There's a mental health and addiction strategy, tobacco, early years. All these pieces fit together. So Thrive focuses on physical activity and the food environment, but all these other pieces are really important. And what we need to do is we need to reshape the places where we live, work, and play. As it says up here on the slide, it's not just the idea of everyone needs to make better choices. The choices we make are shaped by the environment, by the choices that we have, which is shaped by the environment that we're in. So a lot of the work is around having the conversations to create change, and Thrive wants to allow those conversations to happen and make sure that there is an environment and the policies that are needed to support that change. What that means is down the road, we're looking to see changes in our community. A simple example where there was community saying we want to make change, I think about the Oval on the Commons. People, it's an opportunity for people, everyone, anyone can go out and skate on the Commons. It brings people together, it's accessible for everyone. A simple change that community helped happen and wanted to see. So I unfortunately have to go to another meeting, so I'm not going to take much longer, and I won't be here for questions, but I will be back at lunchtime. But if you want to know more about Thrive, there is a website. There are some great community videos on the website, because although government needs to make sure there are policies in place to help create supportive environments, it's really about communities coming together and creating change. Sharon at the beginning challenged us to think about what can we take away today to adapt or adopt or adapt. And what I think I'd like you to think about is, are there barriers created by the environment or policies that you work within or you live within that need to be talked about and changed to ensure that all Nova Scotians have the opportunity to be healthier? Thank you.
Well, thank you, Caroline. It's really nice that you've been able to set the stage about physical activity, because I'll be building on that. And I do have lots of slides, so it's nice that all the speakers are different, and some don't have very many. So please bear with me. I have quite a few slides, and I'll just have to hit the high points, though, about our work with gender equity and diversity. So I'm going to tell you a little bit about the physical activity, sport and recreation branch in the Department of Health and Wellness. And I'm going to talk to you about our work to increase the engagement of women and girls in our field. I'm going to talk to you about the gender gap that currently exists in physical activity, sport and recreation. And I'm going to give you a sense of some of the work that we've been doing, some of the milestones that we've achieved in the past couple of years. I'm going to just make you aware that we are using a gender-based analysis plus diversity lens tool to help inform our work in the branch. And we also have recently developed a framework for action, a strategy identifying some of the key areas that we're going to work on in the next few years. And then, as Caroline mentioned, I'll tell you a little bit about the Mi'kmaq Physical Activity Leadership Program. So this is the vision that we have in physical activity, sport, and recreation. And some people refer to us as the PACER branch because it's too long a name to say physical activity, sport, and recreation all the time. So we're PACER. And we're focused on helping all Nova Scotians to live actively every day. And all of our staff were involved in a strategic planning exercise last year, and we've all bought into this vision. We do have regional offices, so I encourage those of you who are working out in the regions to get to know some of our staff out there. And you can see that we're all over the province. We have regional representatives who would love to partner with folks in the health system, and I know a lot of you are working with these individuals already. So in our branch, we really lead government's efforts and collaborate with communities to improve health and quality of life for Nova Scotians through active living. So in regards to inclusion and equity, we have commitments in our strategic plan because it is very important to our work. So our guiding principle states very clearly that all Nova Scotians must receive understanding, respect, fair treatment, and an abundance of opportunities for participation. And within the plan, we talk about improving access and mobilization for segments of the population who have traditionally been disadvantaged. And we've noted that gender equity is our priority at this time because we have excellent data that shows us that women and girls are not as active in all areas of our field as they could be. So we have clear evidence of a gender gap. And whether we look at participating in physical activity, engaging in sports or recreation, whether we look at officiating, leaders in the community, coaching at various levels, sitting on boards of directors of organizations that are involved with physical activity and recreation, the participation and engagement of girls and women is a concern. And when we look at the data about women and girls from diverse racial backgrounds, we find that they're among the most underrepresented in the Canadian sport and recreation system, another concern. And when we look at the physical activity data, we can see that women are less active than men right across the lifespan. And we have lots of great data on Nova Scotia studies. Grade 3, things are almost equal. Girls are getting almost as much physical activity as the boys, but then it starts to drop off. And by the time the girls get in grade 11, very few are meeting the requirement, the physical activity requirements. And that's a concern. And as women age, their activity levels decline. And when we get to the ages of 55 plus, it's very, very concerning, especially now that there are links. We know the links to chronic disease prevention and now the prevention of dementia. So it doesn't matter which population subgroup we look at, fewer women than men are participating and they face more barriers to participation than do men and boys. So there it is. We have a gap. And I don't mean to say that men and boys are as physically active as they should be. No, they're not. It's a concern. It's a concern right across the board. But then we've got this additional concern about girls and women. So if we keep doing things the same way we've always done them, decade after decade, year after year, we're not going to make a difference in the participation rates of girls and women. We need to start doing things differently. And there's lots of reasons why that gap exists. I don't have time to go into them today, but a lot of it is systemic and it's historical. So we need to change how we're going about our business. So there are health implications to this. So women comprise more than half of Nova Scotia's population. But the women today are not getting the health benefits and the social benefits that come with participating in physical activity, sport, and recreation. And that's a concern. So when we look at gender equity, what we're really saying is that we believe it's important for women and girls to be provided with that full range of opportunities that meet their needs. So we're talking about equity. We're talking about a fair distribution of resources and opportunities. So we don't mean the same things necessarily, but we want different things because girls and women are different from boys and men. They may prefer doing different things and doing them in a different way. So we need to recognize those differences and we need to tailor what we're doing to meet the needs of girls and women. And we also have to take diversity into account because, as you know, some groups face greater barriers to participation than others. And so when we talk about being fair and equitable in how we distribute our resources, we need to pay attention to the differences among people, and we've already touched on that today. So we need to look at all the factors that make up individuals, and we look at cultural background, language, abilities, sexual orientation, and so on. So we need to design opportunities that meet the unique needs, interests, and experiences of particular groups. So Caroline talked about how we want to reach large numbers of people, and that's true. We want to focus on the bottom of that pyramid. But we can't just develop programs and think that the one program we develop is going to meet everyone's needs. No, we've got to look at the larger population group, but we've also got to tailor some of what we're doing to meet the special needs of certain populations. So we're taking action in our branch, and it's a complex issue to address, but what we're doing is we're taking a comprehensive approach and we're being deliberate in what we do to help women and girls become better engaged in our work. And we're calling on everyone. We cannot do this alone. We're taking a leadership role in this work, but we're calling on all of our community partners, anyone with a stake in health and wellness and physical activity, sport and recreation. We need them to join us in taking action. And there is a lot of support for our work. We've been asked to take on this leadership role. So here's some of what's happened just in the past couple of years. And this is not new work to us. There's been some great work going on for about 20 years. But in the past 20 years, we've really stepped up. So we have in our branch a disparity reduction task team. There are a few of us that come together, and that's our focus. And we decided with advice from all of our staff that gender equity should be our priority focus in 2010. Then we had a gender equity workshop at a Recreation Nova Scotia conference, lots of stakeholders there in the room saying, we need to do something, will you help us and take a leadership role? So we stepped up to the challenge and we said we would. So then we realized that our staff needed more training. We needed to build the capacity of our staff to start doing things differently and thinking about things differently. And we had staff training on sex, gender, and diversity for all our staff. And then we engaged our staff in helping us develop a gender lens tool that we could use with our work. And I get a message to wrap up, so I'm going to start talking really fast. We then had a provincial leadership forum. We had over 110 people join us. These were leaders from around the province, leaders from school boards and from recreation departments and municipalities and physical activity, sport and recreation organizations who came, focused on gender equity for the day, and again, more support for doing more. Then we found a tool that had been developed nationally by Status of Women Canada called the GA Plus Diversity Initiative and Lens Tool. And we decided, hey, This brings the gender lens together with the diversity lens. We like this approach, and we merged our gender lens tool with this particular tool. And then we developed our framework just in November, and we had a meeting with about 20 experts in the field to help us move forward with what we're doing. So I don't have time to go into our gender-based analysis plus diversity tool, but it's a way that we can look at our policies and our programs and look at what impact they have on different groups, including women and girls and including diverse groups. So this is it. You can go on the Status of Women Canada website. There's an online training program that you can take, get a certificate of completion, and you too will know how to do this. So it's a systematic way of doing it. And diversity, as I say, is recognized within the tool, that we look at gender, the differences between boys and girls, and boys and girls, men and women, and all of the various intersecting factors. Now, what difference has it made to our work? This is just one example. We have a grant program. We work with communities, and they can apply to us for some funding assistance to build recreation facilities in communities. There never used to be any particular mention of differences between girls and women's or special populations. We used our tool to review the policy, and now we have some wording right in the guidelines for the grant that says, facilities should meet the needs of diverse groups of women and girls, men and boys. Facility planning processes should consider how differences in gender and other intersecting factors affect income, design, and use. So in other words, look at your community. Talk to people. What is it they want out of this recreation facility? What is going to meet their needs? And then we've gone on to say that facilities that increase the engagement of diverse groups of women and girls in physical activity, sport, and recreation will be given greater consideration. Wrap up. Okay. This is our strategy. We have a number of things planned for the next few years to help get women and girls more active and engaged and thrive. Don't need to focus on that, but this is exciting. The Mi'kmaq Physical Activity Leadership Program. We actually have physical activity strategies being developed throughout the province in municipalities. It's a partnership between the provincial government and municipalities. There are 44 in strategies being developed throughout the province to increase physical activity levels. And now, just announced in February, that there is going to be a similar program available in the Mi'kmaq communities. So starting with 4 communities, and you can see them there on the screen, and then over time it'll be expanding so that all of the communities and the rest of the municipalities can participate. And you see that that's shared funding arrangement. So that's it. Thank you very much.
I'd like to thank Sharon Davis-Murdoch and the Planning Committee for the opportunity to be with you today to share about spirituality and spiritual care and the strategic directions that we have planned or in the process of planning for Nova Scotia. But first of all, I'm going to give an overview of spirituality as it relates to spiritual care. I've invited a colleague of mine from Capital Health, Buffy Harper, who will give an overview of some of the things that are happening at Capital and at Annapolis Valley, and I'll share briefly about Cape Breton. So spirituality is caring for the whole person. It's an integral component of healing. It's a source of strength in the presence of distress. It is at the heart of our well-being. It enriches all aspects of our life, physical, mental, and emotional, and community. And spirituality is a force that promotes hope. It encourages healing and helps us to embrace ourselves and others. It's expressed through our beliefs, our attitudes, and our practices, and it influences our own lives. It's a part of each one of us. Spirituality enables us to experience the transcendent or higher power. And it involves our family, our friends, It embraces fullness, meaning, and hope in our journey. And some of the things, the continuum of a spiritual well-being would include such things as love and loneliness, gratitude and suffering, acceptance and denial, openness and fear, and peace and anxiety. And spiritual care practitioners, who were historically known as chaplains, and we were historically under the umbrella of pastoral care in Nova Scotia, and is now evolving nationally and provincially and across the other provinces into spiritual care through the initial change in our national organization. Used to be called Canadian Association for Pastoral Practice and Education. And now we have evolved, I think it was 3 years ago when Buffy was actually our national president at the time, and we evolved to being the Canadian Association for Spiritual Practice, Canadian Association for Spiritual Care. And we're evolving in our language throughout the country. We're evolving in the language in our standards. We're evolving in the name of what we call ourselves as professionals. And at the moment, we're floating between spiritual care practitioners or spiritual care therapists. So we're members of the healthcare team. Practitioners, we're trained to respond to persons who are experiencing distress in a number of different areas. And we do this through listening and facilitating communication, assessing spiritual needs and concerns, providing spiritual care and counseling, supporting those facing crisis situations, exploring faith and mortality, responding to religious needs, contacting faith community representatives when requested, and exploring possibilities for reconciliation, leading support groups, as well as guiding through the grief process. And some of the spiritual needs that we encounter with our patients or clients or residents in our healthcare facilities throughout the province include meaning, and the questions are there, things related to purpose, communication, relationships, belonging, hope, values, creativity, and forgiveness. And some of the symptoms of spiritual distress that we encounter and that we watch for, and we encourage our nursing colleagues and our social work colleagues and other healthcare professionals to watch for and to make referrals to us, are the things such as these: fear, pain, anxiety, confusion, depression, anger, hopelessness, loss, apathy, shame, guilt, grief, withdrawal, isolation, resentment, disbelief, conflict, regret, loneliness, powerlessness. Now, historically, I think we were seen as the people that were called when someone was on their deathbed and they needed the last rites. Well, you see that there's a longer list than that for us, and the things that we can respond to through the training that we have experienced. Now, take a minute and just look at these questions and see whether you can answer yes or no to any or all of these. And just let me just put it out there. How many of you have answered any of these questions in the affirmative? So simply that means you're a spiritual being. So I think we can all consider ourselves part of that, and part of if you end up in the hospital or a long-term care facility or whatever, you would be someone who may need our services. And some of the things we're involved with are healing, helping people find meaning. We're often called meaning makers, accepting and reconciling. So spiritual care is for people of all religious beliefs and for those without a faith community. So it's about all of us. Now, just briefly to tell you some of the promising practices that are happening in Cape Breton, we have Spirituality, Diversity, and Belonging Committee, which encompasses our multi-faith committee, our pride committee, and a number of other interest groups in our district. And we've done a number of things throughout the years that we've been involved with the diversity initiatives from the Department of Health. Currently, we're working on upgrading our traditionally what was called the chapel into a worship center that will be open to all faith groups. And we're starting from the bottom up, and we're putting in a hardwood floor, which will be warm and welcoming to our Native communities and Native people. In fact, our chapel, our worship center, I have to change my language, but our worship center is actually used as a holding space for our Native communities. We have 5 in Cape Breton. And when someone is in the intensive care or the emergency department and everything, the family members will often come and the friends to make peace with their loved ones. And so that becomes rather chaotic in the departments. So we have offered up our worship center as the space for people to go when they need to have a space. So the patients are even taken in there at times, as well as the family members. So that was one reason why we wanted to go with the hardwood floor. Then we're also putting in a compass in the bottom of the floor to orientate to the different directions. And I think it's even going to be a ceramic compass in the center of the floor. So I'm quite excited about that, and that of course is with the money we have to spend by the end of March. So we're working on it. We're working with the flooring people, and we're hoping that it's going to happen. They assure us it will. But so that's one thing. And then the other thing that we've done to help everyone in our facility is we've put a multi-faith manual on our intranet, which we adopted and had permission to do so from Hamilton Health Sciences Center from one of our colleagues there. And that's there for all healthcare providers to have access to. And I think it's even gotten across the province, because I've had calls from people, and I always say, get in touch with the people at Hamilton to get permission to use it. So anyways, and we've done a number of other initiatives over the years, but I'm going to let Buffy come now and share with you some of the things that are happening in Capital and in Valley.
Good morning, everyone. I'm very pleased to be here, and I'm thanking Sandra last week for calling me because there aren't very many healthcare professionals, or healthcare, spiritual care professionals in Nova Scotia. In fact, right across Canada, there's probably only about 100 or 1,000 of us who are in our association as certified specialists in spiritual care. So you can imagine there aren't very many of us in Nova Scotia, and we do count on networking and working together and collaborating. So no surprise that Sandra called me last week and said, would you like to be part of this? And instead of just talking about spiritual care in Cape Breton, let's talk about spiritual care in Nova Scotia. And we invited another colleague from Annapolis Valley, Deborah Orton, to be with us. She can't be here today, but we'd like to share something that they are doing in the Annapolis Valley, and we heard a little bit about it from Deanna, so I'm going to shine a light on those workshops that they have in the Valley that have been so very successful. So we're going to start off by giving you a few promising practices that we have in Capital Health. And the first one is that I belong to a group of professional practice coordinators out of the rehab and supportive care portfolio. 3 years ago, we changed the way we looked at managers. Managers became interprofessional. They no longer just supported groups in a discipline. For instance, a manager of social work, or a manager of spiritual care, a manager of physiotherapy. They were clustered around a group of interprofessional people who worked with a particular group of patients. And to add to this, to make sure that we didn't lose the discipline-specific focus that we would need in our own professions, we started this group of professional practice coordinators. So I belong to a group of 7 professional practice coordinators, and I'll just tell you, they're in social work, physiotherapy, occupational therapy, psychology, recreation therapy, orthotics, and prosthetics. And we have an interprofessional manager who manages this group of people. That means we meet and we talk about the whole care of the patient. And so this is wonderful for a spiritual care provider to be part of this group. Acknowledges, as Sandra says, the importance of the spiritual dimension of the patient. And there are many hospitals and healthcare facilities that do not have anybody, particularly a spiritual care professional. But I think it's this practice of including spiritual care in some way in your professional practice is a very, very important issue. And I know that many professional practice groups in hospitals involve mostly nurses. And just to, to say what a breath of fresh air it is to have all these different disciplines being part of the professional practice network. The second promising practice that I'd like to talk about is our Professional Advisory Council. And we all started having professional advisory councils, and for a long time in spiritual care, it involved church leaders. So there'd be bishops and ministers from different churches there. Our Professional Advisory Council now, and I'm just going to tell you who's on it, just to give you an idea that we are looking to the community. Because we are such a small discipline, we know that we need to have community contact. So so people on our Professional Advisory Council are two people from the Interfaith Council of Halifax, and specifically not of the religious traditions that we already have staff chaplains. Most of our chaplains are Christian, so we are looking for representation from faith groups that are not Christian. So on our Professional Advisory Council right now, we have a Jewish rabbi, we have a leader from the Hindu community. We also have a patient or family or veteran on our council. We also have a staff member, either a physician, nurse, or an allied professional. We have one chaplain, one denominational chaplain, so that's a chaplain who is hired by their church to work in the hospital, so they're there also. We have teaching supervisors who actually supervise students in the hospital, so they are also part of our group. We have representation from the Atlantic School of Theology and the Acadia Divinity College, because we know that research and education are an important part of spiritual care. And we also have the manager of interprofessional practice and the director of the rehab portfolio as ex officio members of our group. So it is a widely diverse group and very different from the traditional professional advisory council that often just had chaplains and clergy involved. So we're really trying to make it a broader group. And of course, what is happening is we're learning a lot from each other. No surprise that we would learn from each other much more than we would if we just had a very homogeneous group. The other practice that I'd like to talk about, a promising practice, is our Sacred Spaces Committee. And we meet regularly, and again, several members of the community are part of that group, along with chaplains from the hospital and our diversity coordinator. And we have changed our traditional chapels. We are now calling them places of prayer and meditation. And we have really responded to the needs of our physicians, our families, and so on, who are looking for places to go, not necessarily in the traditional sense. So we have special areas for Muslim prayer, and they're just being used all the time. There's people coming in and out all the time. We have a place where people can meditate. We have meditation cushions. We have an area with a water feature where people can just go and sit. And the most popular thing we have in our places of prayer and meditation are journals. And we put the journal there, and they are written in daily. People come in and just write. People who can't talk about what is happening to them or what is happening to their loved ones are very comfortable writing in those journals. And we're continually replacing the journals because they're being filled up. But it seems to be a place where people can write what they feel in a very troubled time. So those are some of our practices at Capital Health. And I'd like to talk about what Deborah Orton has done in the Annapolis Valley. She's by herself there, so she's the coordinating chaplain, and she works very much with the community. And they have been having these workshops and she's working with the diversity committee there, as you heard. Spiritual care is part of it, but they had goals of conference. And so what they've been having is these conferences, and they charge $20 for the day. And you get your breakfast and your snacks and your lunch, and you come and you learn. And she has publicized this all over the province. They have 60 to 70 people coming regularly, and of course they're getting funding, and I think they're getting funding from you, from the Department of Health and Wellness, to have these. So for somebody who is by herself in spiritual care, Deborah is using what she has, which is her community contacts and her work with the Diversity Committee, to make sure that spiritual issues are not missed or not forgotten. And she was just talking about the success, and she says that there's ongoing relationships built with the leaders in the community, First Nation, Buddhist, Muslim, Christian, Jewish, and the Rainbow community. Healthcare professionals, students, and university professors from around the province have attended the workshop. Healthcare professionals, spiritual and religious leaders, doctors from the Valley have been able to attend. She talks about the funding coming from here and how important that is, because when you charge $20, it means that people who are coming from different areas need to maybe get the day off, and maybe they're gas, but they're not spending a lot of money, and all of a sudden it becomes possible for people to attend. And that's what she said. Healthcare professionals have been able to take the learning back to their teams and share it with their team members. Healthcare professionals have developed new insights into how they might honor those values, cultures, beliefs, and spirituality may be different from their own. Healthcare professionals have learned how values, culture, beliefs, and spirituality play a major role in the overall healthcare of patients, decisions patients and or family members have made with regard to the healthcare plan. So these have been very successful, and just an idea that if you're in a rural community, and you might not have many resources in spiritual care, that there are, when you work together, and especially with these diversity groups, that there's a possibility of doing something like this without spending a lot of money. The last thing I want to say, I guess, Sandra, you're finished, right? Yeah. So the last thing I want to say is that there is a diversity of what is being offered in spiritual care in Nova Scotia, and we want to learn more about that. And I have been working with Sandra and Evelyn Schaller from Cape Breton to plan an event, and we're going to have an event at the end of April, April 26th, and it's going to be in Truro at the new hospital there, and it's going to be talking about strategic directions for spiritual care right through the province of Nova Scotia. So all of you here now are going to be invited, anybody who would like to attend, because as I said, many of you don't have chaplains or you don't have spiritual care providers in your hospital. It doesn't mean that you don't want to be connected or know that that is part of who you're caring for, the patients and the families. So we are planning this event. There will be more information coming out as it gets closer, but April 26th, it's on a Friday, and it's going to be at the new hospital in Truro. So those of us who haven't been there are going to get a chance to have a tour. Okay, thank you.
Thank you very much to all of you. What perfect timing to talk about gender equity and diversity on International Women's Day and making those connections. And thank you for, as somebody with spirituality and from Muslim faith, I can relate to and validate great work. Thank you so much. And we now open the floor for questions. We have about 10 minutes for that.
I'm David Elliott. I'm from the Department of Health. And I'm just reading down loss, apathy, shame, guilt, grief, fear, pain, anxiety, confession. These are all sort of co-opted as terms referring to spirit and whatnot. But I feel a little bit like a gay person where the conversation is about marriage being between a man and a woman. Where do atheists fit in this? People who don't believe in spirituality. And you say, it is at the heart of our well-being. That's an exclusive statement. if an atheist is not spiritual, do they have a lack of well-being? You have to be very, very careful the way you talk about this, okay, that you do not exclude a very quiet but also sizable part of the population, okay? Most atheists are in the closet. I'm a practicing atheist, and I find this discussion about spirituality and faith and whatnot often makes rather proprietary claims to human emotions, human feelings, and also I note that it says responding to people who are experiencing distress. Atheists experience distress in medical situations,
David,
and I find,
can I just ask you a question?
yeah,
So, do you think that you have to believe in God to be spiritual?
I believe that the way spirituality is usually defined has some faith-based component to it and some belief in a higher power. And my version of atheists rejects the notion of spirituality because spirit tends to be a faith-based construct.
And that was, in the past, spirituality and religion were very connected, and we're moving further and further away from that, and there's certainly a wider, and I think Sandra was really trying to show a very wider definition of spirituality.
And I understand, and I actually am gratified to see that there was an attempt,
Yeah.
okay? But until you have an atheist on your committee, I don't think you are inclusive and have not embraced the diversity of religious or non-religious belief.
Certainly, we've, in the Canadian Association for Spiritual Care, are moving more and more away from, using very specific religions, because we know, I mean, you go to the IWK, and even my own children, I think some of my children would say they were atheists too, right? So that's becoming more the norm. People are not religious, particularly as they used to be. Do people still have spiritual distress? We say yes, because they're in the hospital. There's a lot of existential questions. Who am I now that I just had my leg amputated? How can I survive now that I've had this stroke? So these are questions around your own existence as a person. So we look at those as spiritual issues. So a far broader definition really than whether people have a belief in God or not. It's more about, this is more than my physical, it's not just my physical being. There's more to me than that. There's my thoughts, my heart, who I love, who I have relationships with. Though that's what makes me as a person. So I think we're looking at our personhood and saying there's more to us than just the physical part of our persons. So hopefully, we probably aren't there completely. We're working on this. I think these are good points, and we do need people like you. Yeah, maybe we should have an atheist on our professional advisory council.
So thank you, David, for bringing this forward and sharing it with us. Promising practices are about what is working well, and there's nothing to say that more cannot be included in that. So thank you. Any other questions?
Hi, my name is Linda Bayers. I'm with the Self-Help Connection. Just wearing my researcher hat, Heather, this is a question for you or an observation. I find it hard to believe that men are more physically active than women, considering childbearing, housework, not to mention the rigors of breastfeeding or trying to find a place to do it. Hey, sisters. So I'm wondering in your research if you took that into consideration.
Yes, you raise a good point, and it certainly is something we're aware of. And we're asking for new and better ways to measure physical activity. For the longest time, all we had was the Canadian Community Health Survey, and that was self-reported information. There would be a survey, And then folks would be asked, you know, how active they are in various questions like that. So according to that data, right, you could see that men were saying that they're more active than women. But now there's a new study, and that information had people wearing accelerometers. And so an accelerometer actually measures how much you are moving. And that type of data is much more reliable. It tells us a lot more when you're actually measuring someone's physical activity levels. But what we're seeing with that data is the same trend, that the men are moving more than women. And when you look at how we're measuring physical activity levels in the schools, we've got an excellent set of data from our Keeping Pace program. And the students there are wearing accelerometers as well. And so, you actually have very reliable data again as to how much they're moving. And there's no question we see quite a drop-off among girls after grade 3. And as I say, it's just really, really troubling when you look at how many girls are active in grade 11. Yeah.
I'm Jane Maloney from the North End Community Health Centre. Sorry for not introducing myself before. At the risk of sounding like the language police, can I make 3 requests about the words that we use? There are no such thing as low-income people. There are no such thing as children living in poverty. As far as I know, very few children live alone. And there are no such thing as communities of people, cultures with special needs. So they're terms that we use, and they're often meant with the very best of intentions, but for the people that they're being used about, they're often very offensive. Thank you.
Thank you for that, Jean.
Hi, folks. I introduced myself earlier, but it is Jim Guthrow with Health and Wellness. And this question is for Sandra and also for Buffy. First and foremost, great presentations, folks. With the integration of services that have been happening throughout the province as it relates to the districts, acute care, long-term care, and home care, and one of the things that was highlighted in your presentation was in regards to the numbers, or the lack thereof, numbers as it relates to spiritual care. Has there been any discussion or dialogue around that in regards to the integration of services, again, as it relates to acute care, long-term care, and home care, but also the sharing of services amongst districts and how you can provide services outside acute care, and maybe you do. So would you be able to comment on that?
In Cape Breton, we have had some funding from Department of Veterans Affairs for the long-term care patients who are classified in a certain category. I forget what it's called, VIP, I think. They have had funding for that. We do not have specific funding for our long-term care facilities. In fact, in Nova Scotia, long-term care facilities, the spiritual care of the residents is taken care of by the recreation coordinators. And I think that's primarily, rather than being a therapeutic practice, it's more of a planning and organizing services that they would have attended in their own communities and that type of thing. And of course, the distribution of funding throughout the province is different from district to district in terms of where the priorities are for your senior management, and they decide where to put the funding and whether or not spiritual care is a priority and whether it's to be a funded service or not. In fact, in Nova Scotia, the only government-funded services for spiritual care are at Capital, in Cape Breton, and the exceptions to that would be Gasha, Antigonish in particular, has a chaplain. I think because of the historic connection with the church and the diocese, and Valley Health Services, even though they're doing great work in spiritual care, their position there is not funded by the District Health Authority, but is funded by a special foundation that the community rose a number of years ago. So anyways, I don't know if you want to add anything else, but it's our dream that we will have equitable spiritual care throughout Nova Scotia, and that's why we're stepping up to the plate, just as they've done in Manitoba and British Columbia, and to see that our profession is truly recognized and professionalized and given some priority in the province. So,
Okay. There's one more question, and then we'll move to our next.
Okay, this shouldn't take very long. I'm Daryl Collins, and I'm with the Department of Health and Wellness. Sandra and Buffy, this question's directed to you. You're talking about a chapel that's being turned into a worship center. Where is this at? Where is this located at? Like, if I wanted to go to it, where would I go?
well,
Physically go to it?
Well, Buffy spoke about the space in Capital, but we're working on the space at the regional hospital in Sydney.
Is this something that's going to, are you going to try and spread this kind of thing throughout, like, the hospitals that have chapels in them? You are?
That's what today's for.
Yeah,
Today is for adapting and adopting. So.
Exactly. That's what this is. In fact, we have a policy now for our places of prayer and meditation, and part of our policy says that every building that belongs to Capital Health is going to have some kind of place of prayer and meditation in it. Do they have them now? No, but we're working towards that. We started off with the ones that were there originally, and we've changed them and made them more inclusive. And when we made them more inclusive, people are starting to attend and be there, right? They come.
Thank you. And there will be more opportunities for this kind of discussion to go on. And I would like to thank everybody for being here today for the presentations. And Sandy will walk us through the next segment.